soumettrons les questions donc, au docteur Yadav pendant la session. Donc, restez connectés jusqu'à la fin. Les informations sur le certificat de participation et les prochaines étapes. Et maintenant, donc, place au docteur Yadav. Kaushal, donc nous allons lui donner la parole. Yes, Dr. Yadav. Dr. Yadav, you have the floor.
Yeah, thank you. So, try to make this interaction more participation from your side also. If anything you can discuss with us in between the presentation also, we can have a talk and questions in between also, and at the end also. I would also like to know how is the practice there and how it should be in ideal scenario. Can we share the presentation?
Donc, le docteur disait qu'il aimerait que cette session soit interactive et si vous avez des expériences ou bien des partages, vous pourrez donc participer également et il aimerait savoir comment est-ce que la pratique se fait de l'autre côté, la pratique de la médecine et de toutes vos activités professionnelles, comment ça se fait de l'autre côté. OK.
So, how many of you who are participating knows about the large intestine cancer, which is cancer of colon and rectum, combinedly called as colorectal cancer? How many of you are dealing with these patients who are having cancer in the intestine, rectum and colon, whether by assisting or by treating?
Donc, combien d'entre vous ont des connaissances sur donc, le cancer du côlon ou le cancer du rectum, donc le cancer du côlon en général?
Dr. Kaushal, I think we, because generally participants are shy, so I think we should ask them directly. Dr. Gulfin, have you
So I think
have you encountered any case with the large intestine cancer, like as Dr. Kaushal said, colorectal cancer? Dr. Gulfin? Come on, doctors, when it is interactive, it is better.
Yeah, don't be in a frame that you are not able to, you will be pointed or asked. Whatever you know, you should tell that. Only then there is benefit of this meeting, although it is online, but it will give you most benefit to you and to us also only when we keep on talking with each other.
Dr. Kaushal, we have a comment by Dr. Chanda Stephen. He says he do have patients, but usually refer to the next level as they are working on a first level hospital.
And in if anyone is not want to just say anything, they can write down in message also. Varun and other can help us in reading those messages without telling the name also. So you can just type in the message also in between.
Dr. Kaushal, Dr. Chanda Stephen has raised a very important question. Many doctors, they work at a first level or second level hospital. Then they face this. Yeah, Dr. Mikasha.
Yeah, I am one of the general surgeon in general hospital from district. What we do is it is being common currently, like proximal colon, like sigmoid, descending colon, and the transverse colon. We can do it. First, we stage with the CT scan, and we do colonoscopy. Then, as a general surgeon, we can do the proximals, but the distal one, those which require APR, anterior abdominal resection, we send for colorectal surgeon.
Okay. So, as such, colon cancer are the third most common cancer in the world, and they are the second most common cancer if we take only the cancer which are increasing nowadays. So it is so common across the globe that no one can spare them from the knowledge of colorectal cancer. Everyone has to be aware about them. So these are some of the risk factors which almost all of you know about this, that what are the increasing factors and what decrease the risk. We are not go into much detail of these, but there are certain warning signs for which the evaluation should be done to rule out the colon cancer. And most common sign is bleeding, that may be fresh bleeding or that may be altered color of the stool. So this is a sign. At that point of that time you should do evaluation for colorectal cancer. Another is anyone having a decrease in the hemoglobin level which is unexplained by other causes, or someone having either frequent constipation or diarrhea which are not getting relieved and continue for more than 3 weeks, they should be evaluated for early diagnosis of cancer of colon and rectum. As you told that this distal colon like sigmoid, and you are doing APR also, these signs are more common in that. For the proximal colon, these signs are less. They may have the blood loss in small amount which is unknown to them, so anemia may be a presentation. But when they become large size, then they cause obstruction also. 60 to 70% of these patients present in stage 3 or stage 4 with the advanced disease, when they cause more symptoms and patient have long treatment. If we detect in early stage, then the treatment is also short and results are also good. So very important point is that whenever you see such kind of the symptoms, you should do the evaluation of the patient to rule out the colon and rectum cancer. Now, so I don't know what are the
Doc, Doctor, please, if you may allow, let me translate this point for the symptoms. OK. Donc, nous avons pour le cancer du rectum, comme nous l'avons dit, ou bien le cancer du côlon en général, donc les symptômes sont donc les saignements. Lorsque nous avons des saignements de coloration foncée ou très, très sombre, donc, ou bien des selles qui sont très, très sombres, colorées, et lorsque nous avons donc de l'anémie, donc perte de suite ou de réduction des taux d'hémoglobine. Donc, nous avons également l'altération au niveau des transits intestinaux. Donc, tout ça, ça permet de distinguer que ça, ce sont des symptômes. Nous avons également donc l'obstruction intestinale, la diarrhée. Et donc, tout ça, ça peut représenter des symptômes qui peuvent indiquer qu'on doit faire des examens pour savoir si la personne n'a pas un cancer du rectum. Yes, sir.
Dr. Kaushal, I want to interrupt you for a minute because there's a very important question that Dr. Chanda Stephen has asked. And generally, many doctors in Africa face this dilemma. Like he works at a first level hospital, he sees such cases, but as per protocol, he's to refer them level 2. While in India, you see multiple patients from different African countries, and even at the highest level, they are not able to treat the patient. So generally, what should a doctor like Chanda Stephen do? Generally, we suggest that nothing stops you from referring the complex case to the Indian oncologist as well, so that the patient can have a parallel line. And but if it comes from a doctor like you, that would make more sense to Dr. Chanda.
Many patients from African countries which present to India also faces the same problem, that in the evaluation and in the diagnosis and then reaching to the treatment, it usually takes a very long time. Initially, they don't get this proper line of the management, and when they present it to us, the disease is already at an advanced stage, so which translates into a longer duration of the treatment at the India, and sometime when they are in stage 4, there are limited options of the treatment. So
very relevant, sir. Right now, I mean, your colleague, Dr. Amit Goel, urologist, similar what you said, sir. The patient came to Max Gurgaon in very advanced on the based of Ethiopian reports, and they had a surgery also. It looked like surgery case, but the cancer is metastasized now. Options are limited. For patient
So,
interest, it's very relevant that they refer to you early.
So what they can do whenever they see a patient in the primary care, and these are the warning signs, these are very important signs. All of them should understand this. Now, not even the patients who are less than 40 years of the age or at the 30 years of the age, they are also not spared, because our habits are changing, lifestyles is changing everywhere in the world. So we are seeing the patient of the colon cancer at the age of 30 years and 20 years also. So whenever these symptoms are there and abdominal symptoms not getting corrected, either they should do colonoscopy or CT scan, which is easily available, so that's any doubt that can be confirmed. And whenever these patients present to them, they can even connect to with us by your through that they can ask us that they are having a patient like this who is not getting treated. These are the symptoms, and what are the initial investigation should be done. Even at that initial level, they can come in our contact.
Thank you, sir. Vinegar, can you translate this for the French audience? Because this is
Yes,
a very
yes.
important message that Dr. Kaushal has given.
OK, donc dans la boîte de dialogue, il y a un docteur qui a soulevé une question qui était c'est-à-dire que le docteur avait posé la question, quelles sont les pratiques et quels sont les trucs que vous faites ou bien vous faites en Afrique. Et donc, il a essayé de dire que comme eux, ils travaillent à un niveau 1, donc de prise en charge hospitalière, donc lorsqu'ils rencontrent des problèmes, enfin, des patients qui ont des difficultés telles que ces cancers-là, donc ils font référence, donc ils recommandent le patient au niveau 2. Donc la question c'était comment est-ce qu'ils devraient faire dans ce genre de situation. Donc le docteur Kaushal explique qu'en réalité, même au stade initial, lorsque le patient vient à votre niveau, vous pouvez déjà entrer en contact avec le docteur Kaushal, peut-être à travers Jivo, et il va donc vous donner des instructions sur, par exemple, les examens préliminaires à faire ou bien les directives à suivre pour pouvoir prendre en charge efficacement ce patient. Et si nécessaire, donc on pourra donc faire une plus grande prise en charge un peu plus spécifique si le stade est avancé. Donc le patient peut venir même jusqu'en Inde ici pour suivre des traitements. Mais ce serait bien donc d'entrer en contact avec le docteur Kaushal au plus tôt que possible. Yes, sir.
Is my presentation visible to all of you?
Yes, sir. It's visible. We can read properly.
So at the level 1, can they advise CT scan to the patient? Can our doctors
Stephen, as level 1, can you advise CT scan? Yes. Dr. Chanda Stephen, can you advise CT scan at level 1 to your patients?
No. For a patient, yes, for a patient who has like bowel habit change and decrease hemoglobin level for unexplained hemoglobin level and bowel habit change, like caliber of stool change it. For this patient, what we first do is we send colonoscopy.
Yeah. So you can do colonoscopy and CT scan whenever there is doubt, and you should have very less. You should means if you have any suspicion, you should do that without delaying the time, and it is the only way to diagnose them in early stage. Is there any screening program in your country to diagnose colorectal cancer in early stages? So beyond 40 years of the age, fecal occult blood test or fecal immunohistochemical once in year and colonoscopy once in 10 years can be advised for screening also.
Okay. So
Okay.
Dr. Chanda Stephen has responded like they do not have a CT scan as a first level. Dr. Chanda, as Dr. Kaushal said, you can draft a direct question to your Jivo relationship manager and will share it with Dr. Kaushal so that he can guide you further in management of that case.
Yes. So, and then
Dr.
for
Mekasha,
workup, yeah.
sorry, sir. Sorry,
Yes,
sir.
yes,
I
yes.
think Dr. Mekasha, you were talking to Dr. Mekasha and I interrupted. Sorry, Dr. Mekasha, please. carry on.
Yes. Yeah, occult blood test is easy. Occult blood test formal one was as a surgeon, as a general surgeon, we can send, and it can easily be done in our primary as well as general hospital. So that is the only thing early we do. Otherwise, like genetic level investigation are not available in our setup. That is the only one, and the colonoscopy, they will go to the tertiary hospital and bring the results.
So at least fecal local blood is available and that can be done. It is not very specific. It may miss some cases, but at least it may help in some cases also. And the ideal workup for a patient of the colon and rectum cancer is colonoscopy and biopsy, MRI of the pelvis, CT scan of thorax and abdomen to check for metastasis, whether in liver or lungs are clear, or PET CT if it is available. And tumor marker for colon and rectum cancer is serum CEA, blood level. I think that can also be done at primary level, serum CEA.
OK. Donc ici, ça c'est la prise en charge ou bien comment est-ce que le patient est pris en charge. Donc, premièrement, on fait la coloscopie et on fait la biopsie, pardon. Donc, la coloscopie et la biopsie. Donc, ces deux-là sont très essentiels au début. Donc, le docteur échangeait avec un autre de vos collègues. Donc, il demandait est-ce qu'eux, ils ont la possibilité d'envoyer directement un patient de niveau 1 pour faire un scanner. Donc, il a dit que oui, dans certains cas, c'est possible, mais la réalité, c'est que c'est pas toujours disponible dans tous les hôpitaux. Et donc, ils font juste donc, la coloscopie. Et maintenant, au niveau nous avons également l'IRM du bassin. Donc, ça permet également d'avoir donc une vision claire de ce qui se passe. Et on a également donc le CECT thorax plus abdomen. Donc, si c'est possible ou si c'est disponible, c'est pas dans tous les hôpitaux qu'on a ça. On a aussi le PET, CECT. Donc, ça aussi, c'est un peu si c'est pas disponible. Maintenant, pour l'imagerie, donc, ou bien les marqueurs, on utilise le SCEA. Donc, le SCEA, c'est le marqueur utilisé pour pouvoir distinguer les cellules cancéreuses des cellules non cancéreuses. Yes, sir.
So, anyone want to ask regarding what workup should be done or any queries regarding this workup?
Est-ce que quelqu'un a des questions? Est-ce que quelqu'un aurait des questions sur cette partie-là, ce que nous venons de discuter? Qu'est-ce qui doit être fait au patient? Si quelqu'un a des questions, vous pouvez soit mettre ça dans le chat, soit vous pouvez donc parler.
Okay. For MRI of pelvis and CT scan, the problem is the MRI we have in Ethiopia is not the one with good slides. So what we prefer is the CT. Actually, the standard textbook order MRI for pelvic, colorectal, rectal tumors, but the slides here is not good. So we still focus on CT scan even for pelvis.
So MRI is only required or is most helpful when the cancer is very low in the rectum to see whether the muscles of the pelvis are free or not, whether a stoma will be required for patient or not. At that time, it is helpful. Otherwise, in the rest of the cases, CT scan is good enough.
Donc, le docteur dit que, en fait, l'IRM, c'est nécessaire seulement dans les cas où on veut voir la position du cancer. Est-ce que c'est si bas que ça et à quel niveau il se trouve? Sinon, déjà avec le scanner, on peut s'en sortir.
So, whenever we manage patients of the rectum cancer, one of the very big problem is that many patients fear that their rectum will be removed and they will have the permanent stoma and they have to pass the stool and flatus. inside the stomach bag attached to the abdomen. So nowadays, in most of the cases, normal passage is possible. Whenever we do surgery for the rectum cancer, our goal is to achieve a free margin in the proximal part of the colon and the distal part of the rectum, and whatever at the lowest level cancer is, to complete it surrounding free from all the muscles and in the mesorectal fascia, having a negative margin at that time, and complete all the lymph nodes which are draining that part of the rectum. So you can see this picture where on which principle we do the surgery, and it is followed all over the world. This holy plane, or a plane in which the surgery of the rectum cancer is done. When we do the surgery, the rectum part is completely removed, and we can go between internal and the external sphincter of the anal canal. Also, this plane should be free. Only then we can do this surgery, which is intersphincteric resection, and we can save the normal passage even in cancer which are lying very low in the rectum. We don't require a very large margin for those, because these are done in embryological plane, and if technology is available, it can be done. One of you has said that APR is most commonly done there, but it is possible to save the normal passage in most of the individuals. They have temporary stoma for 2 to 3 months. After that, that can be reversed after intersphincteric resection. So any question regarding this? Because this is very important finding and very important technology, which is still not practiced in many parts of the world.
Okay, let me translate that. Ok, donc sur la diapo précédente, le docteur expliquait que le but pour lequel on fait généralement les opérations de cancer, il y a certains patients qui sont inquiets par rapport à ce que leur rectum soit complètement enlevé et qu'ils souffrent toute la vie. Donc, le but, c'est en fait les marges de résection distale et proximale. Donc, les marges de résection distale et proximale n'ont pas de différence significative entre le terme de suivi ou la récidive locale. Lorsqu'on compare les marges donc rectales distales de 2,2 à 2,9%, et enfin 2,2 à 2,9 et 3 cm. Donc, il maximise la marge proximale d'au moins 5 cm et la longueur de la marge distale de supérieure ou égale à 2 cm. Donc, pour les tumeurs situées à moins de 5 cm de la verge anale, donc la marge distale minimum est de 1 cm. L'étroitesse de la marge distale doit être confirmée par une coupe congelée préopératoire. Donc, il a expliqué ici sur cette image que même si le cancer est bas au niveau du sphincter, donc vous voyez qu'on peut toujours, avec cette technique avancée qui s'appelle Holy Plane, donc on peut essayer de faire l'opération d'enlever le rectum et de toujours permettre aux patients d'aller au sel tranquillement sans problème. Donc, si vous avez des questions, vous pouvez toujours les poser.
Okay. Dr. Abdinisar, I think Dr. Kaushal, I think some participant missed the English part. What you were saying is that a very important message that many parts do not have this surgical operation where it's possible. But we have a follow-up question from Dr. Yegerem on what you shared. He's saying, are you saying even for distal rectal CA, can we do
Yes.
anastomosis?
I am telling this presentation only because it is possible in distal rectum cancer also. You can see this presentation which I have told, that it is lying low in the rectum is not the problem. Problem is that whether we can remove the cancer completely or not. That is the problem. So it has been proven by various guidelines that even minimal distal margin is 1 centimeter is adequate, and we can do intraoperatively frozen section at the time of the surgery to check whether all the microscopic cancer cells has been removed from there or not. It is possible only because of identification of this holy plane where the cancer tends to spread upwards. It spreads not as we go down and down, it doesn't spread downwards, it spread upwards along its natural embryological supply of the lymph nodes and natural embryological planes. So if we remain strictly within those planes, we can go even between the internal and the external sphincter of the rectum. I will show you here in the details in this part that when we do the surgery, one part is removed from the from abdomen and down from the perineal part, and at that time we can go in between these internal and the external sphincter to the lowermost possible. Only that this plane should be free between external and the internal sphincter of the anal canal. If this is possible, then coloanal anastomosis even in the distal most part of the rectum is possible.
Donc, ici, il y a une question qui a été posée au docteur de savoir est-ce que dans le cas des cancers du rectum distal, est-ce qu'on peut toujours faire le CA? Donc, ensuite, il explique que oui, en fait, la question se trouve au niveau de est-ce que nous pouvons enlever la totalité de la masse cancéreuse ou non? Et c'est à ce niveau qu'on fait la gymnastique. Donc, ici, il expliquait que donc, la partie externe et la partie interne du sphincter, on doit pouvoir enlever, enlever cette masse-là sans toutefois obstruer le canal anal du patient. Donc, c'est pour cela qu'on jongle, on peut même remonter, puisque plus le cancer s'étend, il commence par monter et à remonter vers le haut. Donc, même s'il est bas, on peut également faire des gymnastiques en essayant de couper ou bien de faire des coupes entre donc les parties externes et les parties internes du sphincter pour pouvoir avoir un taux de réussite assez élevé et sans endommager donc la vie du patient. Yes, sir.
Dr. Kaushal, we have a follow-up question again by Dr. Yadav. Dr. Yadav, it will be great if you can ask the question directly to Dr. Kaushal, but I'll repeat your question. Sir, the question is, in a setup where frozen section is not available, how can we be sure free margin? How can we be sure free margins, and how do we follow them post-op?
You follow the natural plane, which is avascular, do the sharp dissection between internal and external sphincter, and on gross examination, try to take the 1 centimeter of the margin in lowermost. And if it is above, then try to take the margin of 4 centimeter, 5 centimeter, or 3 centimeter, whatever is possible depending on the location of the tumor. But try to achieve at least 1 centimeter of the normal mucosal margin in the lowermost cancers, and follow your surgical planes. Then you can, it would be negative, and you can follow up the final histopathology report, whatever then it comes.
Donc, ici, donc il y a une question de suivi qui posait la question de savoir est-ce que s'il n'y a pas de partie vraiment qu'on peut fixer pour pouvoir pour pouvoir faire l'opération, et le docteur disait donc il faut pouvoir essayer de maintenir dans la partie mucosale donc un minimum distal de marge qui est égal à environ à 1 cm. Et donc avec cette marge là on pourra donc pouvoir faire l'opération sans craindre quelques risques. Yes, sir.
So upper and middle rectum, it is easy, and in case of low rectum, we have discussed that we can do intersphincteric resection also. These are some of the photos and clips which we do the surgery like this, that we remove all the lymph node structures. This is the aorta, and till the origin of the inferior mesenteric artery where it arises, remove all the lymph nodes from that part, and then go down deep into the pelvis till the pelvic floor, and from there we reach between the internal and the external muscles.
Donc le docteur explique un peu donc la procédure d'opération.
Then again, from the perineal part, this lone star retractor is applied, and we take the margin under vision. We know where we are cutting, and then take the adequate margin and join both the parts, and then it is removed completely like this. So we have discussed this already.
Kaushal, there's another question from Dr. David Mukeba, who is from Bujimai region with very low healthcare infrastructure. His question is, if we don't have all these paraclinical tests in our region, what should we do to help the patients?
If you don't have,
all these
can you repeat the
paraclinical, yeah, if they don't have these paraclinical tests in their region, which you
So
had
I think
prescribed
the
in
things which you
what
can do under control, you should do those things. If they cannot be done under your control, then it would be better to send them or refer them to a center where these can be done with utmost precision, because cancer gives only one chance.
Vinegar, can you translate this? Because the doctor
Yes,
was...
yes. Et donc, il y a un de vos collègues qui a posé la question de savoir si dans notre région, nous n'avons donc pas ces examens paracliniques, que devons-nous faire pour soulager le malade? Et le docteur Yadav expliquait qu'en réalité, c'est tout ce qui est possible à votre niveau régional, vous pouvez le faire, mais si ce qui est nécessaire ou ce qui est important, qui est basique, si vous n'avez pas donc le dispositif nécessaire, il serait bien de référer le patient à un centre qui dispose de ces équipements pour pouvoir prendre en charge convenablement le patient. Yes, sir.
So yeah, so like these advances in the rectum cancer, there are advances in the colon cancer also, because for treatment of the colon cancer is not just hemicolectomy, right? In case of cecum or the ascending colon, it is not just right hemicolectomy. Nowadays, the technique which we call for these cancer is central vascular ligation and complete mesocolic excision. Means the feeding vessels of the cancers are ligated right at their origin in their roots, so that all the lymph nodes are removed and complete fascia is removed along with that. Like in this picture, we are go beyond the fascia, so that all the problems are solved, and it has better survival compared to the standard technique, and overall survival is better. So this our technique has been published in international journals also. You can see that this case is we are doing by laparoscopic way, and now we are ligating all the lymph nodes are removed, and this ileocolic vessel arising from superior mesenteric vessel is ligated right at the origins, and all the fascia is taken along with this. This is the retroperitoneal fascia above the duodenum, which is taken completely, so that patients have best outcomes.
Doctor, what is the name of the technique? I mean, the procedure?
This is, you can say, complete mesocolic excision with central vascular ligation. You can say CVL with CME. You can say CME.
CMI, OK. Donc, ici, nous avons donc les dernières avancées technologiques dans le domaine de la prise en charge de ce cancer du rectum. Et donc, il y a une procédure qui s'appelle donc CVL et CMI. CMI, en fait, c'est la ligation centrale vasculaire plus une excision complète de la mésocolique. Donc, c'est complete mesocolic excision. C'est ça la procédure. Donc, avec cette procédure, on a donc un rendez-vous, un résultat assez efficace et très avancé, sans toutefois mettre en danger trop le patient, parce que vous pouvez voir sur la vidéo comment ils sont en train d'élaguer la cellule cancéreuse, de séparer ce tissu-là du reste des organes. Yes, sir.
So, nowadays, you see in colon and rectum cancer, most of the time open surgery also gives good result, and equally results can be achieved with the laparoscopy also. and they have advantage that lesser hospital stay time and better recovery. And nowadays we are doing robotic surgeries also because of recent advances that robot has also proved to be equally effective. And at our hospital in Gurgaon, we are having the most advanced robot Da Vinci Xi. And with these, we are doing the surgeries of colon and the rectum cancer.
Donc, nous avons également, donc, avec la laparoscopie, et nous avons également, donc, si on fait une opposition entre la chirurgie robotique et la chirurgie laparoscopique. Donc, nous voyons que nous avons également des avancées avec les robots. Donc, il y a un robot qui s'appelle le Da Vinci. Le robot Da Vinci nous permet de pouvoir faire des opérations, puisque ce robot a des bras qui permettent de pouvoir toucher le patient à des endroits très, très précis pour pouvoir faire une opération sans toutefois faire des erreurs. Et il a également beaucoup d'écrans sur lesquels on peut suivre en temps réel donc l'opération. Yes.
So this is all about these advances. We can have question and answers also.
Donc, c'est tout pour la présentation. Si vous avez des questions, si vous avez des inquiétudes ou bien des endroits que vous n'avez pas compris, vous pouvez poser des questions. Le docteur est prêt à vous écouter.
So I think we keep on interacting in between. So most of the questions are covered also. So still, if anything is being asked, we can always connect now, and we can connect later on also if you have any problems or workup in any of the patients. So
Okay,
I think
Dr. Kaushal, in that case, many times things sync up and when they have relevant patients. So let's wait for, okay, we have
yeah,
again
I will.
Dr. Raghuram
So
in a patient
in a
with
patient with
sigmoids
sigmoid core
with
with peritoneal seeding and
seeding.
liver mets. So patient of sigmoid colon who is having
Yes, sir.
only liver metastasis, and if they are limited liver metastasis, maybe 1, 2, or the 3, in those cases, liver metastatectomy can be done at the time of the surgery or in a second stage, provided they should be we should be able to remove them completely. If liver is completely studied in both the lobes, at that time there is no role of curative surgery, only palliative chemotherapy. Similarly, in case of peritoneal seedings, if there are only peritoneal seedings and no other site, in those cases cytoreductive surgery with high PEC, that gives a survival advantage of 50% in case of colorectal cancers. So this is a good option for them, but the disease should be limited and it should be combined with chemotherapy before and after that. So, and the place of the neoadjuvant chemotherapy is that in case of colon cancer in stage 1 to 3, there is no role of neoadjuvant chemotherapy in colon cancer. In case of lower rectum cancer, our practice is to follow neoadjuvant chemotherapy and radiotherapy in cases who are having either T3 disease when muscles are involved or those who are having lymph nodes which are involved. So in early stage, T1, T2 and N0 disease, direct surgery is the option, and in case of advance, it should be given neoadjuvant chemotherapy and radiotherapy followed by surgery. In stage 4, most of the treatment is by chemotherapy only, and in limited cases like liver and the peritoneum, which I told you, give 3 months of the chemotherapy, then those surgeries followed by 3 months of chemotherapy.
OK. Donc, il y a une question il y a une question qui a été posée.
Vineeta, have you translated?
Please go ahead. No,
Okay.
no, I was about to.
Okay. Okay, please go ahead. Yeah, please translate.
OK. C'est que, il y a une question qui a été posée de savoir, par exemple, si chez un patient atteint d'un cancer du sigmoïde avec avec carcinose donc péritonale et une métastase hépatique, qu'est-ce qu'il faut faire? Donc, le docteur essayait de donner donc quelques indications selon lesquelles donc il va falloir suivre ce patient avec de la chimiothérapie juste avec avant et après et donc l'opération. Et il va également falloir prendre certaines dispositions pour pouvoir donc accompagner le patient de façon efficace. OK, thank you, sir.
Okay, Dr. Kaushal, can we wait for 2-3 more minutes if there is any follow-up question, and then I can give vote of thanks and discuss with them,
Yes,
announce
yes.
an online OPD with you for relevant cases.
Sure,
Dr.
sure.
Kaushal, an online OPD is when our African doctor partners, they have a relevant patient, they collect the details, share the information with us, which we share in advance with you. They invite the patient to their clinic, and you can join via Zoom while the doctor is also present there, so that the consultation is effective. And if they need help from India, patients get a very trusted and channel where they are guided by doctors on Indian as well as African. Okay, sir, I mean, we can always, if we have your permission, right, we can conclude the session, and any follow-up questions team will share with you. Many times we get questions after okay, so we have one more question. It's in French. Let me translate it for you.
He said, can we have a module or,
Okay. So, Vinegar, tell them that we have recorded the session. We will provide link to the webinar recording. And also, Dr. Kaushal has shared the presentation English and French. We will share that also.
OK, great. Donc, pour votre information, vous aurez donc accès au lien de l'enregistrement de notre webinaire et donc vous pourrez y accéder. Également, le docteur Kaushal a donc ajouté, enfin, il a partagé la présentation en intégrale, version anglaise, et nous avons également la version française. Donc, tout cela vous sera partagé en temps réel. Il suffit de contacter l'équipe de Jivo et vous l'aurez.
And now, if I have permission, let's conclude the session.
Yes.
Dr. Kaushal, thank you for such a brief. No, Dr. Yegram, you will be getting certificates of modules as they are signed by the doctor also. It takes time. Please share. Oh, no, there's a question, sir, not related to the topic about participant certificate from previous sessions. So you can share with on your Jivo work group which all webinars you attended and you haven't got the certificate. We'll get it issued as early as possible. So Dr. Kaushal, thank you for such a brief, concise, and really knowledgeable presentation. And I think this is the first session we are able to stick to the time limits. And thank you all for participating. I know how difficult it is for a doctor to take time out on a Sunday. That's the only day you have for your families and personal stuff. And everybody who is here, thanks a lot. And so, as you've seen, Dr. Kaushal, he's a surgical oncologist, and even his education credentials are one of the best in India. He graduated from PGIMS Rohtak, which is one of the top institutes in India, and it's very difficult to get admission there. And thank you, sir. I mean, the clarity and the precision you brought to this presentation was very helpful, and I hope the African doctors find that helpful. And to all the Jivo doctor partners, thanks for. We organize these webinars as parts of Jivo mission to bring global medical expertise closer to you, your clinic, and your patients. If you have a patient who may benefit from Dr. Kaushal's specialized specialty and specialized cancer care in India, we can organize an online OPD with Dr. Kaushal. You can write the message in your Jivo work group. You will also be getting an email tomorrow with relevant links. You can request your participation certificate. If you have a relevant patient, you can fill the details there, and team will organize everything for you, including taking time from Dr. Kaushal and helping you through the process. And
they can discuss with, apart from colorectal cancer, they can discuss other cancers with us also, because we are treating breast cancer, gynae cancer, and lung cancer also.
Yeah, okay. So, my bad. So, today's topic was about rectal cancer, but as a surgical oncologist, you can discuss cases like breast cancer, lung cancer, and others. And you will get an email. You will have a link where you can request your participant certificates, and you can access recordings. And thanks for participating. Today we are a small movement, but the idea is to foster this participation and collaboration with Indian doctors and African doctors, so that better patient gets better care, and you as doctors also benefit from expertise of senior doctors like Dr. Kaushal. Thanks a lot. Vinegar, can you translate this for the French audience?
Yes. Donc, merci à toutes et à tous d'avoir participé au webinaire médical de Jivo aujourd'hui. Donc, notre remerciement va tout particulièrement au docteur Kaushal, chirurgien oncologiste de l'hôpital Max de Gurgaon, pour sa présentation claire et enrichissante sur donc, le thème d'aujourd'hui qui était diagnostic et la prise en charge du cancer du rectum. Votre intervention a été très précieuse pour notre communauté médicale. À nos partenaires médecins africains, nous vous remercions sincèrement pour votre présentation, pour votre présence et votre participation active. Ces webinaires donc, font partie de la mission de Jivo pour rapprocher l'expertise médicale mondiale de vous et de vos patients. Si vous avez donc des patients qui pourraient bénéficier d'un traitement spécialisé en Inde, vous pouvez désormais donc réserver une consultation en ligne, donc ce qu'ils appellent online OPD, avec le docteur Kaushal via Jivo. Et donc, c'est un moyen pour nous, donc, un moyen simple d'obtenir un avis d'expert avant une éventuelle référence ou bien un voyage en quelconque. Donc, vous pouvez rester connecté avec nous pour recevoir donc, votre certificat de participation, l'accès au enregistrement. Et donc, vous aurez dans votre boîte mail également un lien, vous pouvez avoir accès à tout et d'autres opportunités de formation. Donc, merci encore. Et donc, le docteur disait qu'à part le cancer du rectum, nous avons donc le cancer du sein, le cancer du foie, d'autres types de cancers, puisque c'est un oncologiste chirurgien. Donc, ils traitent tout ça dans leur hôpital et ils sont spécialisés dans cela. Donc, merci encore et bon dimanche à vous. Donc, et à vous revoir pour un nouveau webinaire au sein de Jivo. Merci.
Yes. Thanks for your time. Okay, thank you.
Thank you.